Well, thank you again. As Adrian mentioned, we try to summarize what we found is important to stress in terms of working with a normal population. This is healthy people. That was our baseline to collect information. Before to move to any pathology, it was important to understand what is the reality of the population. So we have three main segments. The first one is the North American native people, that it means Mexican people. This is mainly the work done by Marta in Mexico. This is a very nice summary of native populations in Mexico. As you know, in Mexico there are 25 million people recognized as indigenous one. That is probably the biggest group in Latin America, and they have 68 indigenous languages. That means that it is very difficult to communicate with these people without knowing their language. Mexico has 43,000 towns inhabited by indigenous population. Wide spread of indigenous population is an additional problem. However, Marta chose the most close populations together to try to capture that information. So she summarized that her objective was to identify the genetic and environmental factors specific to Native American people that can affect their responsibility to the drugs. The barriers are, as mentioned, the first one is the language. Although we are from there, the problem is that most of us are not native speaker people. Cultural difference is another common problem, and what is very important is the profound health disparities, because what is a constant in our health system is that unfortunately indigenous people has several difficulties to access to health service provided by the government. Also, mistrust in genetic research by the communities is something that we carry over from the past, and communities situated in remote locations make even more difficult, not only to access, also to take samples and to manage that samples. The challenge, obviously, is to ensure that the results benefit to the community. It's quite important in our environment to stress that people will not feel like a research subject or only as a source of information. They need to understand that what we are doing will help them to get better health in the future. And ensure that the results are adopted in public health policy is a very big challenge, because most of the time, and as you can imagine, the problem is that what we are doing and even publish never take into practice in our own countries. It's very difficult for us to approach to the Ministry of Health and to communicate them our results, and even worse, to get changes from them. The main results from North American native population is that the pharmacogenetic biomarkers identified in the European and North American population, Caucasian population, neither predict the response of drug therapy nor avoid the adverse event in Native American from Mexico. Some proposals that we have been discussing: the partnership with the community leadership and the healthcare providers is important to keep working there and to continue having their support. Return results in culturally understanding format is important because communities need to understand what really means the results and what for are them. The capacity to sustain collaborative research with the communities focus on their health priorities. We as researchers need also to listen what the community is concerned about, to try to respond accordingly with our support. Some regulations are important for most of our countries, this has been a challenge permanently to try to avoid, misuse of research. In some countries, more than in others, the problem is that some people used to go to take samples and never get back with the results. Even they patent some of the genes and things like that. So that is something that we are really concerned and try to avoid for the future. So we have been working with the state to get proper regulation, IRB approval, Ministry of Health involvement in the research, etc. And obviously to explain clearly to the community and to the subject what for the research is and what are the potential benefits of that. We are also very interested in to get the participant consent to be part of the research. It's important to respect those subjects and to understand from both sides what important is to get the participation but the consent at the same time. So in conclusion from Martha's long work in Mexico population is that the personalized medicine strategies must be developed specifically for Native American based on their genetic and ethnic background. That is why the work done during this decade is important, because we get now such an information. And this interaction with environmental factors is the next step to understand better how to proceed. It's critical in importance to decrease morbidity and mortality rates in this population. As we already know now, they are different to the Caucasians, so we need specific knowledge from those populations. The second segment that we are referring to is the work done by Dr. Ronald Ramirez in Nicaragua, representing the Central Americans and Caribbean Miskito and Mestizo populations. This is very interesting because we are referring to the Istmo of Americas, high level of inequality and poverty, and high vulnerable area to natural disaster, as most of you know. We are talking about a huge population, 48 million, Amerindians, 20% of that population, and a gross national income per capita of $6,000. So that is easy to understand how the reality is. Mean years of scholarity, 7 years, difficult to communicate, obviously, and the mortality rate by communicable diseases is 106 per 100,000 population. So based on that reality, what Dr. Ramirez was concentrated is in doing research, clinical research in those environments. So medical treatment, by concept, need to reflect biological and non-biological variability to the drug response. He has been concentrating difference in culture and perceptions. The Central America area has a strong influence of traditional medicine that make even more complicated to set up intervention, because people still truly believe in traditional medicine and strongly request for traditional medicine at the same level or even more than Occidental medicine. Ethnicity can be also an important factor and need to be taken in consideration because it's based off population pharmacogenetics. Mestizo Nicaraguan population has a very interesting genetic polymorphism of cytochrome P450, as you can see represent here. 2D6, 6% are poor metabolizers. 2C9, 23 has decreased or diminished activity, and 2C19, 15% are rapid, ultra-rapid metabolizers. That means that most of the drugs that are metabolized at the hepatic level are affected in this population in a different degree. Adjustment of doses need to be taken in consideration. Unfortunately, if you review the prescribing information available in Central America, none of the drugs are referring to the adjustment of doses because this data is not in place for those drugs. We are talking about antipsychotic, antidepressant drugs, anticoagulants, and antiplatelet drugs. All of them very strict security margin drugs that are very, very careful to take in consideration. Some barriers that Dr. Ramirez identified to conduct clinical trials, 20% of the clinical trials that are officially listed in clinicaltrials.gov are conducting in developing countries, and from them, 122 are in Central American countries. We are missing financial support. Human capability is a big problem, particularly because human resources not always get back to Central America due to, the limitations there. There is a lack of environment for research. Unfortunately, universities are doing their best, but it's not probably the best setting and is still a difficult place to set up clinical research. The social and political problems are very well known. We are talking about discrimination, violence, inequality, insecurity, and obviously poverty in the region. That makes the typical, unfortunately, proper environment for not well-set clinical research, taking advantage of the reality of the society. And immigration is another big problem because those guys that are fortunate to go outside the region to get training to study, it's difficult to get back to return to the country. And the third area we want to mention is the Ecuadorian setting, the Quechua and the Mestizo population. That is interesting for us because, Ecuador is in the middle of the equator. We have a very diverse environment and regions, and one of the most important areas of our interest for work has been the province of Imbabura. Ecuador has 17 million people. Why we choose Imbabura area to work? Because in Ecuador there is approximately 1 million indigenous people that represent 7% of the total population. And from those, 74% are living in the Imbabura province, so it's probably the most richest one in terms of diversity of indigenous people. What we have been doing there, we try to characterize the genetic and the environmental factors affecting the action of the drugs, both in Mestizo and indigenous people. For Ecuador, Mestizo people is a very interesting situation because we have a strong mixture with the Spanish people. When you have a look what was presenting Dr. Tarazona early in the morning, we are almost 50-50 Spanish indigenous people. We are the most mixture people, so it's interesting to analyze our population. We have some language barriers. It's interesting because in the last years we are facing a deculturation process where native-speaking people refuse to recognize that they are Quechua-speaking people and they prefer to switch to Spanish, so that makes an additional barrier. We have a mistrust of health research. Most of the people feel that researchers are only concentrated in taking samples and never get back with the results for the community. Communities are situated very remote locations, and the health disparities and traditional medicine is an additional barrier to take in consideration. We have a stigma problem that makes very difficult to access for common Occidental medicine to indigenous communities. Just to mention one example, there are very few indigenous physicians that attend to the university to get degree in medicine and get back to the communities. So most of the providers are Occidental ones that do not speak Quechua, and the communication barrier is obvious a problem. So the main result from our area is that the biomarkers identify, not only for drugs, also for characterize the diseases, are based on Caucasian population and are not suitable, are not applicable to predict the response to drug therapy, nor avoid the adverse events, even in Mestizo population, even worse in indigenous communities. Our regulatory framework, very similar to what happened in the other place of the region. We still have a very weak system to try to control research in our area, so it's very important, and we are still working with our authority to get the mandatory review and approval by an IRB before the studies start. We need to explain and demonstrate to the community what is the value and get them involved as much as possible. And obviously all participants need to provide not necessarily written, but at least verbal informed consent to guarantee that they are really conscious what is happening. Some improvement areas, the partnership with the community is essential to keep still working. Return results in a cultural understandable format is essential. We need to improve our capability to communicate with the communities in the proper way, them to assimilate the results and what means really, and the capacity to sustain collaborative research is quite important. For us, has been a very nice exercise, for example, to get the people from here, from Universidad de Extremadura, to go to the community and, being face-to-face with the people and show who are those guys, and they are the counterpart of our studies that have been doing this collaborative research. So that is the summary of what we have been doing in the different communities to try to show you our perspective about this kind of work. Thank you. No.
This was very good. I have a question to Marta. You made a very strong point, and it was also reflected by other speakers, that what we know of biomarkers from Caucasian populations do not fit these populations. But it will be never yes/no. Could you? It's a scale, because. And could you reflect on that? Is it totally not, or is it sometimes yes and sometimes no? Could you reflect on that? Because we have experts here in the room. In a pharmacogenomic association, you see always a higher likelihood to have this efficacy or this adverse effect. So the question is it yes, is it binary, or is it a scale that you can say, well, whatever we know, it's not usable?
Sí. Claro, la pregunta es en base a tu comentario de que los biomarcadores farmacogenéticos no se aplican de los caucásicos a los indígenas. ¿Es completamente un sí o no? o es una variación, hay un rango en los que algunos aplican en términos de eficacia o algunos no aplican, y en términos de efectos adversos algunos están presentes más o menos. Creo que está apagado.
Thank you. Sometimes some biomarkers are okay. Algunos biomarcadores son útiles, pero son muy pocos biomarcadores útiles en la población. Es necesario buscar los marcadores propios para cada población, porque hasta el momento hemos visto que no son del todo necesarios o útiles para predecir la respuesta a los fármacos. No hay un sí categórico, ni hay un no. Algunos sí son útiles, pero son muy pocos y no nos sirven para predecir la respuesta a fármacos.
Yeah. Most of the markers are not suitable for the indigenous communities. There are some few, however, most of them seems not to be applicable. So that is why it's necessary to identify the proper ones. Yes.
Gracias.
We will make it shorter because we have another roundtable and a general discussion with Professor Levy.
Go ahead. No problem.
I think that's, I really appreciated the presentations coming from Africa. I see a common thread. I looked at your improvements, and it's improvements that we talk about generally. Did you actually work out with communities on the how? Because I think with our groupings, we're actually struggling with the how. How did the communities, did you discuss with communities your improvements and how they would want to see the improvements implemented? And that's what we grapple with, so some direction in that.
Sí, la pregunta en general es muy interesante los datos, pero ¿cómo se logra la participación de la comunidad y cómo se logra que la comunidad sepa los resultados y cómo se logra que se puedan dar cambios en la comunidad?
Es muy complicado. La ayuda que podemos darles nosotros hasta ahorita es entregando los resultados acerca de su estado de salud, porque es complicado explicarles esta parte de farmacogenética y farmacogenómica. Hasta ahorita nosotros hemos solo entregado resultados explicándoles su estado de salud y cómo podemos ayudarles para que tengan más accesibilidad a los fármacos, preguntándoles cómo se sienten cuando toman fármacos que el médico de la comunidad les da gratuitamente. Es en lo que les podemos ayudar. Es una barrera muy importante el lenguaje. No, es difícil que ellos nos entiendan. Siempre usamos a alguien de la comunidad que nos traduce, nos ayude a traducir.
That is a very difficult issue because the concept of pharmacogenetics and pharmacogenomics is far away of the normal communication process. So what at the moment they are doing is basically referring to general health and trying to provide community at least some advice about the general health and try to link that with the use of drugs and how they are feeling with the drugs and what might be the problem with the drugs, but still is difficult to understand what is the link with pharmacogenetics or even worse with the pharmacogenomics. Another big problem is communication, because as we do not speak native languages, most of the time we need a translator, And it's even more complicated to explain to the translator so the translator can transmit to the population what we are trying to say. And, you know, in that process, the message normally is not exactly the same. So that is why in the practice still is not something that we can really be satisfied that is effective, really.
I'm somewhat concerned with his statement that biomarkers do not work in the indigenous population. As you know, biomarkers are a hot potato in clinical medicine. So there are few established biomarkers for diagnosis, prognosis, and response to therapy. So to repeat all the biomarkers, all of these studies again, may not be cost effective. The solution is to provide access to the population to old and new medicines and observe the response to therapy. And so after the responses, for those who fail, then you do the pharmacogenetics or genetic studies, because otherwise we will be not investing properly in the resources available. So I think that the statement that does not work, the biomarkers do not work, is a very strong one, which is not necessarily corroborated by the scientific knowledge.
Yes. Lo que está comentando él es que la afirmación de que los biomarcadores no aplican para comunidad indígena es uno muy fuerte, es quizás exagerado, porque claro, si se analiza cada uno de los biomarcadores, la posibilidad de que se encuentre que no aplican es muy alta. Sin embargo, sería mejor ver qué es lo que está fallando y entonces ahí buscar si es que el biomarcador aplica o no aplica, porque entonces se vuelve poco costo efectivo repetir absolutamente todo.
Sí, estoy de acuerdo. Sin embargo, hay que tomar en cuenta factores ambientales que también pueden influir y que puede que no, el biomarcador en este caso pues no sea de mucha utilidad, ¿no? Sí, claro. Sí,
sí,
gracias.
Absolutamente. One of the general comments is that we probably are picking up too late the history because most of the drugs are already in use and in practice. So now to try to get back and analyze is not cost effective. But thinking in the future might be very rational to try to, from the very beginning, include native population to get the perspective, something similar like is happening with Asian or some other populations, for example. Yes.
We will have a debate. We have another roundtable about patients, and most of these questions can be taken over. So, Janice,
sí,
Eva is at home, and you can take at the end because it's another.
Voy a hablar en español. Una de las cosas que he observado es el hecho de que, por supuesto, ustedes están generando evidencia que nos avisa de que tenemos problemas potenciales en el uso de fármacos. Sin embargo, lo que no se ha hablado mucho es si han habido de cualquier manera medir el efecto iatrogénico de no tomar en consideración estas variedades genéticas. Porque yo creo que si usted me podría demostrar cuánta morbilidad se presenta por usar un fármaco en una población, eso tendría un valor político muy importante. Un ejemplo que me vino en mente inmediatamente, cada uno de nuestros países tiene una lista de medicinas esenciales. Un ejercicio teórico que sería muy interesante es ir a través de esta lista de medicinas esenciales y ver cuál de ellas tienen un potencial de crear este tipo de problemas. Porque al final de cuentas, ¿quién es el que debería beneficiarse de este tipo de estudios? Ustedes hablan de las comunidades. Las comunidades se benefician indirectamente después que los que toman las decisiones políticas del sistema de salud llegan a nuestros pacientes. Entonces también tenemos que hacer un trabajo un poco más y no lo vi en ninguno, es cómo hacen que los que deciden las medidas sanitarias se involucran en todo esto.
The question was that you can say in English.
Yeah. What I was saying basically is it's very interesting. However, what we have not tried to measure is what is the disease burden impact of not taking in consideration these genetic determinants. So, and a theoretical example that I was mentioned could be very interesting. Each country basically has a list of essential medicines. Theoretically, you could go to that list of essential medicines and say which one of those has a potential. Because the point here, I think, is to create awareness, political awareness, so that the political decision makers in the health systems see this as a relevance. Otherwise, talking about the impact of this at a community level, it's a wishful thinking, because the communities basically use what the system gives them. Okay, they do not decide what to use or not to decide.
Yeah, I will take very short because it's affecting to me. We have been for 16 years producing genetic data, and our concern now is how to put this data at the community level, social level, and political makers. What we are doing now, this is part of the TV set, is one. We are going to communities. It's complicated. We have two experiences. One was in Otavalo Valley, a group of molecular geneticists, physicians, nurses. We arrived to the community, and we were adapted to their own rituals. We went for a day. First, they gave me baptism, and they gave a name. I'm called Guaira now in Otavalo Valley, and they were explaining to us how they understand medicine. And they were lovely. We were having lunch together, and at the end of the afternoon, we were telling about genetic, the heritage, the family-related problem that we came across. And the second, it was with the Mayans, just a month ago. Again, another baptism with a lot of, but we were for a day adapted to it with Julio will tell. So it takes time. You cannot give just a piece of paper. Second, society. We made an alliance with the American Network of Radios, and this TV record that you are doing, and later we are doing record, will be broadcast for all America. And third, for policymakers, we are planning a conference with drug regulatory agencies in America, which is quite difficult to explain to the data. Concerning to PAHO, when Professor Rego was at PAHO, we asked them to do the same job that I'm doing at EMA, a European Medicine Agency, which is provide biomarkers, a different level of evidence, or do recommendations. We offered to do that free, WHO. So far, since he left, there's no answer. So now I pay by the Spanish government, so I can tell that freely. Because this is very logic. If we're doing that for EMA or FDA, why not to do the same thing for WHO? So, and he's the guy training pharmacovigilance, and one of the leaders of pharmacovigilance in Latin America, specifically in Central America. Maybe you can talk about the lack of control side effects, which is...
Partimos de una realidad. Nuestras poblaciones, para empezar, tienen poco acceso a los medicamentos. Y a los pocos que tienen, no son seguros. Y estos estudios que estamos haciendo están orientados a estudios de salud pública. Estamos advirtiendo que en nuestras poblaciones hay diferencias farmacogenéticas que pueden predecir con mucha precisión la incidencia de muchos efectos indeseables. Y más importantemente, por ejemplo, estoy totalmente de acuerdo con usted, si nosotros demostráramos que efectivamente la variabilidad genética está asociada a mayor incidencia de efectos indeseables. Precisamente, pacientes con síndrome Steven-Johnson, necrólisis epidérmica tóxica asociada a penicilinas, por ejemplo, estamos intentando demostrar que existe esa asociación, que los pacientes que tienen un problema de marcadores genéticos, metabolizadores lentos, que tienen esta dificultad, tienen una mayor incidencia de este fenómeno. Hemos tenido problemas con pacientes que desencadenan estatus epiléptico por disminución de los niveles plasmáticos de los anticonvulsivantes e interacciones con otros medicamentos, etcétera. Entonces yo creo que lo que estamos tratando de hacer no es llevar hasta los pacientes individualmente o a las comunidades individualmente el beneficio. Estamos advirtiendo a la comunidad médica, oigan, por favor, los medicamentos en nuestras poblaciones, por alguna variación genética, van a provocar respuestas diferentes. Por tanto, el beneficio que se recibe y que se está trasladando es esta información de la que la comunidad médica que prescribe los medicamentos muy probablemente no es consciente de estas diferencias. Y lo que estamos tratando de advertir es que hay estas variaciones y que nuestros gobiernos, efectivamente, los sistemas de farmacovigilancia son muy débiles e inexistentes. ¿Y por qué razón? ¿A quién le conviene que no existan y que no sean funcionales los sistemas de farmacovigilancia? Personalmente llevamos 25 años haciendo esfuerzos por montar el sistema de farmacovigilancia en Centroamérica. Y aquí habrá personas que saben que esto ha funcionado muy mal. Incipientes movimientos en el Guatemala, en El Salvador y en Nicaragua, pero ¿cuál ha sido el desarrollo de estos programas de farmacovigilancia? Entonces se nos hace difícil demostrar con evidencia dura que hay esta asociación. Y el mensaje que queremos dar es que efectivamente...
You need to translate.
Correcto.
So it would be...
Okay.
Yeah.
I saw him green face.
Okay.
Yeah, what Dr. Ramirez is trying to say is that the pharmacovigilance process in most of the Latin American countries is still a very weak process. And the reason is that we don't get a culture of pharmacovigilance to reporting side effects. So it's quite complicated for the government to really capture and understand what the problem is to take actions against that. Not clear the reason why it's so difficult to do that, but taking in consideration that we are talking about minorities is even worse because the number of the accessibility to drugs is lower than general population, and the capture of side effects is even lower. So to move to the next step, decision makers and the relationship with security of the drugs is far away still from our results.
Thank you so much, Enrique, and the rest. We will move around for the other round table. Thanks to you. Thanks to the translators.